Good afternoon, dear student. Today we have new topic and discuss about chronic hepatitis. So chronic hepatitis represents a series of the liver disorders of varying causes and severity in which hepatic inflammation and necrosis continue for at least 6 months. Mild forms are non-progressive or only slowly progressive, while more severe forms may be associated with scarring and architectural reorganization, which when advanced lead ultimately to cirrhosis. Classification of chronic hepatitis, but old classification. More than 6 months, similar feature with acute hepatitis, pathological classification. Chronic persistent hepatitis, mononuclear infiltration. Lobular hepatitis, equal prolonged or slowly resolving hepatitis. Multifocal hepatonecrosis, periportal fibrosis. And chronic active hepatitis, equal mild severe necroinflammation, monoinfiltration, and piecemeal in-bridging necrosis. And new classification in based on cause, grade, stage. What about cause? Chronic viral hepatitis caused by hepatitis B plus D, or hepatitis C. Autoimmune hepatitis based on serological distinctions, drug-associated chronic hepatitis, and a category of unknown cause of cryptogenic chronic hepatitis. Stage. The stage of chronic hepatitis, which reflects the level of progression of the disease, is based on the degree of hepatic fibrosis. When fibrosis is so extensive that fibrous septa surround parenchymal nodules and alter the normal architecture of the liver lobule, the histological lesion is defined as cirrhosis. Staging is based on the degree of fibrosis as characterized on a numeral scale 0.6 HAI and 0.4 METAVR IR. And you may see table with histological grading and staging of chronic hepatitis, histological feature, histological activity index for classification or numeral scale HAI, and for METAVIR. And what about grades? Grade histological assessment of necroinflammatory activity in based of examination of the liver biopsy. An assessment of important histological feature includes the degree of periportal necrosis and the disruption of the limiting plate of periportal hepatocytes by inflammatory cells, the degree of confluent necrosis that links or form bridges between vascular structures between portal tract and portal tract, or even more important, bridges between portal tract and central vein, referred to as bridging necrosis. The degree of hepatocyte generation and focal necrosis within the lobule, and the degree of portal inflammation. Several scoring systems that take this histological feature into account have been devised, and the most popular are the Histological Activity Index, HAI, used commonly in the US states, and the METAVR score used in Europe. Based on the presence of the degree of this future histological activity, chronic hepatitis can be graduated as mild, moderate, or severe. And what is FibroScan? FibroScan is a useful test in almost any patient is whom a clinician wishes to stage liver fibrosis. The main drawback of FibroScan testing is that cannot be performed in all patients. Technical limitation of the test preclude its use to patients who have ascites, individuals who are morbidly obese, and all patients who have large amounts of chest wall fat. And FibroScan induce an elastic wave through the liver. The velocity of the wave is validated in a region located from 2.5 to 6.5 centimeter below the skin face. And what is chronic hepatitis? Chronic hepatitis B virus infection has a worldwide prevalence of 291 million affected persons. Patients often remain asymptomatic for years, but many unknowingly transmit the infections to others via perinatal, percutaneous, and sexual exposure or close person-to-person contact. An estimated 15–40% of HBV-infected patients may develop complications such as liver cirrhosis, liver failure, and hepatocellular carcinoma, which represent the common causes of HBV-related deaths. Chronic viral hepatitis, including both chronic HBV and hepatitis C virus infection, HCV, is responsible for approximately 1 million deaths worldwide and 20,000 in the US. And clinical presentation of chronic hepatitis B. Patients with chronic active hepatitis, especially during the replicative state, may complain of symptomatology such as following. Symptoms similar to those of acute hepatitis, fatigue, anorexia, nausea, mild upper quadrant pain or discomfort. If progressive liver disease is present, the following symptomatology may appear: hepatic decompensation, hepatic encephalopathy, somnolence, disturbances in sleep pattern, mental confusion, coma, ascites, gastrointestinal bleeding, coagulopathy. Physical examination of patient with chronic hepatitis B infection can relieve stigmata of chronic liver disease, such as following: hepatomegaly, splenomegaly, muscle wasting, palmar erythema, spider angioma, and rarely vasculitis. And chronic hepatitis B infection is a dynamic process. The natural history of chronic HBV infection can be schematically divided into 5 phases, which are not necessarily sequential. First, the immune tolerance phase. Second, the immune reactive HBe antigen positive phase. Third, in the inactive HBV carrier state. Fourth, HB antigen negative chronic hepatitis B. And the fifth, HBs antigen negative phase. And what about serological markers and clinical significance? If you see HBs antigen, it means acute or chronic infection. If you see anti-HBs immunoglobulin M, means acute infection. If you see HB antigen, means high infectivity. Anti-HBe means low infectivity. Anti-HBs mean immunity. and combined anti-HBC immunoglobulin G and HBs antigen means chronic infection. And combine anti-HBC immunoglobulin G and anti-HBs mean result infection. And diagnostic test, chronic active HBV disease is characterized into HBe antigen positive and HBe antigen negative disease. Subtype wild type of HBe antigen positive disease. Patients have mild to moderate elevation of the aminotransferase. The ALT levels are usually higher than the AST levels. Extremely high level of ALT can be observed during exacerbation or reactivation of the disease, and they can be accompanied by impaired synthetic function of the liver. HBV DNA levels are high during this phase. HBs antigen and anti-HBC of immunoglobulin G or immunoglobulin M type are identified in the serum. If the AST levels are higher than the ALT levels, the diagnosis of cirrhosis must be considered. Subtype chronic HBV, HBe antigen negative disease. Note that although the HBe antigen result is negative in this phase, HBe antigen negativity can be associated with the great HBV DNA replication and more rapid disease progression in patients who carry mutation in either the press core of the basic co-promoter region of the HBV genome. And more details about aminotransferase. ALT, alanine aminotransferase. It is enzyme found mostly in the cells of the liver and kidney. Much small amount of it are also found in the heart and muscles. Normally, ALT levels in blood are low, but when the liver is damaged, ALT is released into the blood and the level increases. AST, aspartate aminotransferase, is an enzyme found in cells throughout the body, but mostly in the heart and liver, and to less extent in the kidneys and muscles. In healthy individuals, levels of AST in the blood are low. When liver muscle cells are injured, they release AST into the blood. AST, however, is not specific for the liver and may be increased in conditions affecting other parts of the body. Gamma-glutamyl-transferase, GGT, is the enzyme that is found in many organs throughout the body with the highest concentration found in the liver. GGT is usually the first liver enzyme to rise in the blood when any of the bile ducts that carry bile from the liver to the intestines become obstructed. GGT levels are sometimes increased with consumption of even small amount of alcohol and may be used in evaluating someone for acute or chronic alcohol abuse. The GGT test is not very specific for the liver and is not useful if differentiated between various causes of the liver damage. And ALP, alkaline phosphatase, is an enzyme found in the several tissues throughout the body. The ALP in blood samples of healthy adults come mainly from the liver, with most of the rest coming from bones. Elevated levels of ALP in the blood are most commonly caused by liver disease, bile duct obstruction, gallbladder disease, or bone disorders. In the liver, ALP is found on the edges of cells that join to form bile ducts, tiny tubes that drain bile from the liver to the bowels. That is needed to help digest fat in the diet. ALT's bone is produced by special cells called osteoblasts that are involved in the formation of bone. Each of the various tissue types produce distinct form of ALP called isoenzymes. Not all patients with chronic HBV infection have persistent elevated aminotransferases. Patients in the immune tolerant phase and active carriers have persistently normal ALT level, while a proportion of patients with HBe antigen chronic hepatitis B may have intermittently normal ALT level. Therefore, appropriate longitudinal long-term follow-up is crucial. Anemia due to a shortness red blood cell serial period is a frequent finding, although hemolysis can be noted. Thrombocytopenia is a rare finding. Patients with severe hepatitis experience a prolongation of the international normalized ratio. The assessment of the severity of the liver disease should include biochemical markers, include aspartate aminotransferase, alanine aminotransferase, gamma-glutamyl transpeptidase, alkaline phosphatase, bilirubin, serum albumin and globulins, blood count, and prothrombin time, and hepatic ultrasound. Usually, ALT levels are higher than those of AST. However, when the disease progresses to cirrhosis, the ratio may be reset. And what about liver biopsy and histological future? Liver biopsy, percutaneous or laparoscopic in the stand means of assessing the severity of disease in patients with future of chronic active liver disease. Although liver biopsy is not indicated for patients with acute hepatitis B disease. They find it in the acute phase and predominantly lobar with generative and regenerative hepatocellular change as well as accompanying inflammation. Necrosis may be predominantly central lobular. The hallmark of chronic hepatitis B infection is lymphoid inflammation, mostly involving the portal tract. However, occasional concealment bodies are seen in the lobule. Hepatocytes then be distended with viral particle may acquire and unusual ground glass appearance of the hepatoxylin and eosin stain. Ground glass cells are seen in approximately 50–75% of liver affected by chronic HBV infections. And treatment for chronic hepatitis B. 3 criteria for treatment prescriptions are used: serum HBV DNA level, serum HLT level, and histological grade and stage. Patient with moderate to severe active necroinflammation and or fibrosis in the liver biopsy with HBV DNA above 2000 international unit on milliliter, and all ALT above the upper limit or normal. Age and comorbidities also affect the decision to treat and with these agents. If cirrhosis is present, treatment should be given independent of ALT or HBV DNA levels. Patients with decompensated cirrhosis can also be treated with oral antiviral agents, but liver transplantation may be required. Immunotolerance patients, usually young with persistently normal ALT and high HBV DNA level, without evidence of liver disease and without a family history of cirrhosis or hepatocellular cancer, don't need therapy but must receive follow-up. The aim of treatment is the reconversion of HBe antigen when present to anti-HBe, and the reduction of HBV DNA to 400 international unit or liter or less measured by sensitive PCR technique. In addition, normalization of serum ALT, histological improvement in inflammation and fibrosis, and loss of HBs antigen reflect a good response. If HBV antigen disappears, remission is usually sustained for many years. Patients usually remain HBs antigen positive, but there is small but incremental loss of HBs antigen anom. And antiviral agents for hepatitis B. Pegylated alpha-2 interferon gives response rate of 25-45 after 48 weeks of treatment. Patients with higher serum aminotransferase values who are younger with viral loads less than 107 international unit on a milliliter respond best. Patient with concomitant HIV respond poorly. Patient with concomitant human immunodeficiency virus respond poorly, and those with cirrhosis should not receive interferon. Side effects of treatment are many, with acute flu-like illness occurring 6-8 hours after the first injection. This usually disappears after subsequent injection, but malaise, headaches, and myalgia are common. Depression, reversible hair loss, and bone marrow depression and infection may also occur. The platelets count should be monitored. In older patients, HBe antigen usually disappears. And oral therapy. Antiviral is very effective and reduces HBV DNA quickly, and there is little viral resistance. Tenofovir is also very effective, has a similar potency to entecavir, as yet no resistant mutant have been described. And lamivudine, 100 milligram a day given orally, is well tolerated. And possible outcomes of hepatitis B virus infection. Acute hepatitis B infection after this may be transferred to chronic hepatitis B after chronic hepatitis and cirrhosis, and cirrhosis may be hepatocellular carcinoma and transferred to this and liver transplantation, and cirrhosis may be transferred to liver failure and may be finished liver transplant of this. And next part of today's lecture, chronic hepatitis C. Hepatitis C is an infection caused by hepatitis C virus that attacks the liver and leads to inflammation. The World Health Organization estimates that about 71 million people globally have chronic hepatitis C, with approximately 399,000 dying from the infection, primarily due to cirrhosis and hepatocellular carcinoma. Epidemiology: 7 hepatotypes identified, many subtypes and quasi-species. In USA, genotype 1A, genotype 1B, genotype 2, 3, and genotype 4. What about outcomes? Hepatitis C establishes a chronic state in most infected patients. Risk factor for progression: old age at infection, alcohol use, co-infection with human immunodeficiency virus, or hepatitis B. Yeah, and during 2025 year, develop from normal liver to carcinoma and this. And pathophysiology: chronic hepatitis C infection-induced immune dysfunction such as impaired T cells functions and inefficient antibody responses. Metabolic disorders such as hepatic steatosis, iron accumulation, and insulin resistance, often associated with type 2 diabetes. More importantly, HCV is one of the major etiologies of chronic hepatitis, and progressive liver fibrosis then lead to development of lethal complications, cirrhosis, for example, cirrhosis on hepatocellular carcinoma. Hepatitis C infection can induce chronic hepatic inflammation with varying activity, which causes progressive liver fibrogenesis and leads to development of cirrhosis. First, metabolic reprogramming included disturbances of lipid metabolism and mitochondrial dysfunction. Several studies highlight the role of the HCV core protein in steatosis and HCC, carcinoma nodal development, as well as in insulin resistance, which is accompanied with intrahepatic lipid accumulation. Hepatitis C core protein was also shown to contribute to mitochondrial damage by impaired mitophagy. The resulting oxidative stress is regarded as a key trigger of carcinoma initiation and development. And hepatitis C proteins were reported to have both pro-apoptotic and anti-apoptotic properties, while proteins' impact on epithelial mesenchymal transition pathway, which promotes fibrogenesis, tumor development, and metastasis. And physical examination. Most patients with hepatitis C don't have abnormal physical examination findings until they develop portal hypertension or decompensated liver disease. One exception is patients with extrahepatic manifestation of hepatitis C infection, such as porphyria cutanea tarda or necrotising vasculitis. Since in patients with decompensated liver disease include the following: hence, since palmar erythema, deep uterine contracture, asteritis, leukocyenia, clubbing, had since icteric sclera, temporal muscle wasting, and large parotid cyanosis. Fetor hepaticus, gynecomastia, small testes, abdominal sins, paralumbrical hernia, ascites, caput medusa, hepatosplenomegaly, abdominal bruit, ankle edema, second body hair, spider, navy, petechia, excursion due to proprietous. And other common extrahepatic manifestations include cryoglobulinemia, membranoproliferative glomerulonephritis, idiopathic thrombocytopenic purpura, and lichen planus. And you may see a lichen planus, you may see icteric sclera, caput medusa. And the most recent recommendation of the American Association for the Study of the Liver Disease, AASLD, and Infectious Disease Society of America, ISDA, recommend initial HCV testing. HCV antibody test is a result of the body's confirmed current infection with a sensitive HCV RNA test, negative HCV antibody test, but clinical suspicion of the liver disease, test for the HCV RNA or following testing for HCV antibody. If HCV exposure occurred within the past 6 months, consider testing for HCV RNA in immunocompromised individuals. Reinfection after previous spontaneous or treatment-related viral clearance. Obtain initial HCV RNA testing. Before initial viral therapy, obtain quantitative HCV RNA testing to document baseline over viral load. Selection of the most appropriate antiviral regimen to use HCV genotype testing for guidelines. And positive HCV antibody test with negative HCV RNA by polymerase chain reaction inform patients they don't have evidence of current HCV infection. And World Health Organization recommended nucleic acid testing for qualitative or quantitative HCV RNA detection, as well as for tests of cure of 12 or 24 weeks following antiviral treatment completion. In areas with limited sources, the World Health Organization suggests using the aminotransferase platelets ratio index, PRI, of the fibrosis for FIB4 score for evaluating hepatic fibrosis rather than other non-invasive tests that require more resources. And you may see here this formula for ratio index and fibrosis for score. Other baseline studies include the following: complete blood cells count with differential, international normalized ratio, liver function test including level of ALT, AST, alkaline phosphatase, albumin, total and direct bilirubin, calculated glomerular filtration rate, thyroid function studies, screening test for co-infection with human immunodeficiency viruses or hepatitis B virus, screening for alcohol abuse, drug abuse, and or depression. Hepatitis B virus testing with hepatitis B surface antigen, as well as hepatitis B surface antibody and antibody against hepatitis B co-antigen. Serum pregnancy testing in women of childbearing age before initiating a treatment regimen that includes ribavirin or that includes direct-acting antiviral agent without ribavirin. And hepatitis C virus genotyping is helpful for predicting the likelihood of response and duration of treatment. Genotyping can be performed by direct sequence analysis, reverse hybridization of genotype-specific oligonucleotide probes, or restriction fragment length polymorphism. In addition to HCV genotype, a growing body of research indicates the patient genetics play a role in the response to treatment. And histological findings. Liver biopsy is not considered mandatory before the initiation of treatment for hepatitis C, but it may be helpful for assessing the activity and severity of hepatitis C virus-related liver disease. However, some experts recommend biopsy only in the following situation. The diagnosis is uncertain, as a co-infection or disease may be present, as a patient being considered for treatment has normal liver enzyme level and no extrahepatic manifestation. The patient is immunocompromised. Lymphocytic infiltration, moderate degrees of inflammation and necrosis, a portal of branching fibrosis are noted as hepatitis C. Regenerative nodules are seen in patients with cirrhosis. Some patients also may have findings indicative of hepatocellular carcinoma. And FibroScan is a diagnosis of hepatic C virus infection. The most important aspect in the evaluation of patients with hepatitis C virus infection is determine whether or not she has cirrhosis. This is the most important part of staging because the specific guidelines define how one should proceed with patients with cirrhosis in respect to screening them every 2 or 3 hours for esophageal varices and portal hypertension and putting them into a program with cross-sectional imaging, ultrasound, computed tomography, or magnetic resonance imaging every 6-12 months for monitoring risk of liver cancer. There currently are 2 alternative methods to change liver fibrosis and few other modalities that are under development. One available alternative is serum testing. A perfect example of a serum test is the aspartate aminotransferase platelet ratio index score, which is AST over control divided with the platelets count. Patients with a high RI score usually have significant scarring of cirrhosis. The 2 most widely used tests for liver fibrosis in the United States are FibroScan, LabCorp, and HepaScore quiz diagnostic. Both tests are very good in terms of their sensitivity and specificity in diagnosing cirrhosis. But similar to biopsy, they are not as accurate to exact identification of intermediate stage of disease. An antiviral therapy for chronic hepatitis C should be determined on a case-by-case basis. However, treatment is widely recommended for patients with elevated serum alanine aminotransferase level to meet the following criteria. Age older than 18 years, positive HCV antibody and serum HCV RNA test results, compensated liver disease, acceptable hematologic and biochemical induce, willingness to be treated and to adhere to treatment requirements, no contraindication to treatment. A further criterion is a liver biopsy finding consistent with the diagnosis of chronic hepatitis. And viral load suppression reduces the risk of hepatitis C, liver morbidity, and mortality. And antiviral agents for hepatitis C. Current treatment is combination therapy with pegylated interferon, which is interferon with polyethylglycol tail, and ribavirin. Pegylated interferon and ribavirin is combined with either of the NS3 protease inhibitor, tenofovir and boceprevir. Other drugs, HS5B protease inhibitors, cyclophilin inhibitors, new types of interferon, and ribavirin analogies are all being developed, which will change future treatment algorithm. Treatment duration with this combination of drugs alone is 12 months for genotype 4 and 6, and 6 months for genotypes 2 or 3, and as short as 6 months for some genotypes 1 patients receive triple therapy. And combination or co-infection, human immunodeficiency virus and virus and hepatitis C virus are at risk for accelerated liver fibrosis and should usually be offered antiviral treatment. And this co-infection should be treated and retreated the same as those without immunodeficiency virus infection once any interaction with antiretroviral agent have been identified and managed. Daily daclotazepam plus sobosbuvir with or without ribavirin is a recommended regimen when antiretroviral regimen changes cannot be made to accommodate alternative HCV direct-acting antiviral medication. However, the combination of ledipasvir, sofosbuvir for 8 weeks is not recommended, regardless of the patient's baseline HCV RNA level. And chronic hepatitis D, the virus that requires hepatitis B virus for its replication. Hepatitis D virus affects globally near 5% of people who have a chronic infection with hepatitis B virus. Several geographical postpones of high prevalence of HCV infection exist, including Mongolia, the Republic of Moldova, and countries of Western and Middle Africa. Populations that are more likely to have HBV and HCV co-infection include people who inject drugs, ingenuous population, and recipients of hemodialysis. HBV co-infection is considered the most severe form of chronic viral hepatitis due to the more rapid progression towards liver-related disease and hepatocellular carcinoma. This is relatively infrequent chronic hepatitis, but spontaneous resolution is rare. Between 60% and 70% of patients with developed cirrhosis and more rapidly than its HBV infection alone. Currently, treatment success rate are generally low. Hepatitis D infection can be prevented by hepatitis B immunization. HCV infection is diagnosed by high level of immunoglobulin G and immunoglobulin M, anti-HCV, and confirmed by detection of HCV RNA in serum. Current guidelines generally recommend pegylated interferon alpha for at least 48 weeks, irrespective of on-treatment response patterns. And autoimmune hepatitis. Approximately 20% of hepatitis of patients with autoimmune hepatitis will be antibody negative. Always consider drug-induced autoimmune hepatitis like liver injury in the DDX of autoimmune hepatitis. If discontinuation of drug doesn't improve condition, consider autoimmune hepatitis. Presence of at least one other autoimmune disease is very common among patients with autoimmune hepatitis. A diagnosis screen for celiac and thyroid disease. So, thank you for your attention. Please leave your question if you have, and write your name and surname under the video, and Good luck, dear student, and see you again. Bye-bye.